So great to be here. I'm a social worker. I facilitate some groups at Sheena's place. I do the friends, families, and partners, as well as emotion regulation for those who have had bariatric surgery or are in the process of it. Yeah. My background is in mental health, and to be honest, I wasn't thinking about talking about myself. I realized I had better. Yeah, my background's in mental health. I work with currently in an early intervention program for individuals dealing with alternate realities. Yeah. But so I've done this presentation before here at Sheena's place, and I'm happy to see some faces out from folks I know. This presentation, I try to cover a lot of material for individuals who are in a place that are thinking about surgery or that have had surgery, for clinicians, doctors, nurses, but a great reminder is that I am a social worker. I am not a doctor. This presentation is not about bariatric surgery in and of itself. I don't know your medical histories, and trust me, you wouldn't want my advice if I did. But it is about the intersection of eating disorders and bariatric surgery, and some of the information, some of the research, some of the stuff behind that. So with that, I'm going to stop chatting. I'm going to start sharing, and let's get into some of the content. So I'm just going to share my screen. Let me make that bigger. All right, just to confirm, we can all see that. Awesome. Okay, so as I said, my name's Sam. I use she and her pronouns. I try not to use language in this presentation that pathologizes body size or eating disorders or disordered eating. But as I have pulled research from the medical and academic communities, there are definitely words in here that do pathologize. It's really hard to kind of get around when you're using that kind of research. Just a trigger warning that this presentation talks about disordered eating behaviors, some in detail. So just again, if you need to take care of yourself, if you need to walk away, if you need to turn us off, all of that's totally okay. And finally, something that's really important. There is extremely little research on the intersection between bariatric surgery and eating disorders. I mean, little tiny itsy bitsy amounts of research. So what we know, frankly, isn't a lot. All right, so this is just an outline of what we'll be looking at today. We'll do some information on eating disorders and bariatric surgery, supporting bariatric clients who have eating disorders, a new emotion regulation group at Sheena's place, some community resources, and then we will move into questions. Nope, what's going on here? There we go. Okay, this is a bit of a busy slide here, but let's just get to it. So what are eating disorders? Eating disorders are when a person has a relationship with food that is harmful to their physical and or emotional and or mental and or spiritual well-being. Often folks think of eating disorders as solely a physical issue. It is not. It is a mental health challenge that affects all domains of a person's life. and they occur on a spectrum. So if we start on the left side of this big arrow in the middle, we see terms like body acceptance and flexible, balanced, and intuitive eating. This is where we hope people kind of are. Although I would estimate, maybe it's because I'm a bit of a negative Nelly, that 99.999% of the world's population don't fit in there. If we go to the other side, where we're looking at eating disorders, and these are eating disorders as defined in the Diagnostical Statistical Manual by a psychiatrist, or what a doctor would say. If we look at some of those definitions, we have things like anorexia nervosa, which is, an intense obsession with restricting, controlling one's eating. There are often rules and compulsions that are driven by the idea that controlling one's body could lead to self-worth, power, freedom. We have bulimia nervosa, which is characterized by a cycle of binging and purging. And binging means eating an objectively large amount of food in a discrete time period and feeling a loss of control while doing so. This can happen in response to hunger from dieting or restricting food intake, or it can happen in an attempt to self-soothe or numb distressing feelings. And they'll try to compensate, and people will try to compensate for that binge purge behavior, compensate for the binge with purging behaviors, which could include self-induced vomiting, laxative misuse, excessive exercise, fasting, et cetera, et cetera. Then we move into binge eating disorder, which is characterized by recurrent episodes of eating objectively large quantities of food, often quickly to the point of discomfort. There's a feeling of loss of control during the binge, often an experience of shame, distress, or guilt. But there's no engaging in those compensatory behaviors. It can be difficult, never mind near impossible, to find affordable, consistent treatment for binge eating disorder, in my experience in our area. And then I've got a OSFED here, the famous other specified feeding and eating disorders. This includes things like atypical anorexia nervosa, which is actually the most typical kind of anorexia nervosa. And that's when people meet all the criteria for AN or anorexia, except their BMI is above 17. Either way, there are serious mental, physical health consequences. And we have night eating syndrome here. When people eat large amounts of food after the evening meal, often waking up during the night to eat, which causes distress. So all of these official diagnoses are, of course, eating disorders. The OSFED is a great catch-all for a lot of behaviors that may or may not, or that don't really fit in other categories. I just want to draw people's attention to kind of under all of that, there's a little dot that says post-surgical eating avoidance disorder. So this is a new eating disorder diagnoses that researchers are trying to get into the next DSM, Diagnostical Statistical Manual, that's been proposed. And this is specific to individuals who have had bariatric surgery or abariatric surgery. And it's very much what it says there, just no desire to eat, the avoidance of eating, Yeah, so that's, again, one particular to just that niche group of individuals who've had bariatric surgery. And in the middle of this big, these big arrows are disordered eating. I won't go through all of the labels. Oh, this is funny. My notes cut off right here. Let's hope I have a good memory of what I was going to say. Yeah, so disordered eating. I won't go through all of these labels. I would say this is where the vast majority of people kind of fall in the world. But there are some that I would like to draw our attention to, as they will, it's good to know what these definitions will mean as we go throughout this presentation. I personally find these definitions have not been really identified well in research and all of that kind of stuff. I would say probably a lot of doctors don't even know what some of these terms mean. But in terms of bariatric surgery and eating disorders, I think it's important to know. And so one of those would be at the bottom of the first row, loss of control eating. And loss of control eating is a mindset that people have. And that's literally the idea of like, I have to eat now. I can't control myself. That could be one thing. That could be a range of foods, but it very an internalized a feeling mindset of I got to get this food in me. Then we will look at the top of the next one, binge eating. Post-surgery, a lot of individuals identify what they call subjective binge eating. And since, if you remember, when I looked at binge eating disorder, the definition is that it's an objectively large amount of food that an individual has to eat to be diagnosed with binge eating disorder. However, post-surgery, individuals can't really engage in an objectively large amount of food because they've had surgery to make their stomach smaller. And so it becomes subjective, where the feelings that go along with binge eating, if they had that disorder previously, those feelings feel very familiar. The behaviors feel very familiar, except instead of eating a lot of food, what a doctor would consider a lot of food, it's a small amount of food. A friend may even be like, well, hey, like that's nothing. I could eat 10 of those. But to the person, they know, like, no, there's something wrong here about how I went about eating that. My relationship there to that food it didn't feel good. It was icky. And the last one is emotional eating. That's at the bottom of the of that column. And that's when we use food to self-soothe, or to celebrate. Except here's the thing, most people in the world use food to celebrate or to self-soothe. You know, how many television shows have you watched where a girlfriend and a boyfriend break up and she needs to eat ice cream or whatever it is? People do that. That's okay. It's when an individual feels like they don't know how to be happy, mad, glad, sad, unless there is food involved, you know, that they feel dysregulated emotionally. I also felt the need, I can't tell, do I have it on this? Yeah. I felt the need to add to this already very busy slide by adding a arrow up and down on the right, because I talk about eating disorders on a spectrum, and the large arrow encompasses that spectrum from hey, this is the way we hope we can eat or hope we can engage with food to, oh, we're engaging with food in a way that feels very or that individuals diagnose us as it being problematic. But also in an individual journey, there's also a spectrum. And I felt the need to include that when someone is diagnosed or has challenges with disordered eating, that can go all the way from lack of awareness to being in that recovered maintenance stage where they're in a place that they do have a good relationship with food. Yeah, so let's see the next slide. I'm tired of this one. Oh, nope, what's going on here? There we go. There we go. So it's important to remember with eating disorders that often we see behaviors with food or weight change, perhaps excessive exercise or other compensatory behaviors. You know, that's what people might see. But a lot of people forget that some of the biggest challenges are things that we don't see with eating disorders. Things like emotion regulation, emotion dysregulation, anxiety, perfectionism, guilt, low self-worth, shame, depression, lack of self-compassion, fear, trauma, and other physical health issues. So again, I just want to emphasize that eating disorders are not just a physical challenge, they are really a mental health challenge. And who's affected? Well, the myth is that eating disorders affect thin, white, wealthy adolescent girls, when the truth is eating disorders affect absolutely everyone. At Sheena's Place, close to 50% of our clients are over the age of 30. 50% of our clients are on social assistance. We have groups that serve Black, Indigenous, and people of color. We have groups that serve trans, non-binary, genderqueer folk. It affects everybody. As well, one reason that this myth may persist is because men and boys, people with disabilities, the Jewish community, people past midlife, the queer community, and people of color all have shown to be underdiagnosed in eating disorders. As well, individuals who are going through major life transitions, this could be pregnancy or job loss, or I don't know, bariatric surgery, can be at a higher risk for an eating disorder. And additionally, I'll probably say this a couple times in this presentation, people of all shapes and sizes can experience all the eating disorder symptoms. So for example, a person who is living in a bigger body can be engaging in restrictive behaviors. We can't assume the type of eating disorder a person has just by looking at them, or even if they have a eating disorder. Excuse me. This is also a really good time to mention that folks with bigger bodies, especially those who engage in behaviors around binge eating, are often sidelined in the eating disorder community, the medical community, the academic community, and, you know, just in society generally. It is thought that people with bigger bodies are lazy and don't take care of themselves and are quote unquote just fat. And people may not take these behaviors as seriously, eating disorder behaviors as seriously as those who engage in eating disorder behaviors who have smaller bodies. This is because of stereotypes, oppression, and the prevalent ideology of diet culture. However, people in bigger bodies who engage in an eating disorder behavior need to be included in the eating disorder community, especially those who engage in binge eating disorder who may be sidelined, because these behaviors can also lead to death, serious physical health problems, and an incredible amount of emotional distress. It's not something to be just fobbed off. So eating disorder etiology, that's the idea, like where does this come from? What are the causes? The myth is, of course, that eating disorders are a choice. Of course, nobody would choose to engage in such a physically, emotionally painful challenge, and yet this myth is prevalent. The causes are biopsychosocial. You guys can kind of read here what some of those are, but I'll just highlight in terms of biological genetics. Research is showing more and more how genetics really plays a role in eating disorders. The psychological, we can see, I'll just highlight emotions and attitudes and emotion regulation and mental health challenges through here, especially because later on I'll be talking about a lot of research that shows how folks with eating disorders have a really hard time regulating emotions, which adds like another layer to the complexity of this, of these illnesses. Social worker, not a doctor. I don't like words like illnesses. Anyway, and another is like there are a lot of social and cultural reasons that that provide reasons why people that are causes for eating disorders. Whew, that was hard. And again, like, you know, there's no one clear answer. Often it's many different causes, all on top of each other. It's very confusing to try to get to the bottom. You know, there is really no bottom. It's all of these things that need to be considered. Yeah. As well, when it comes to looking at causation, I'm sorry, I'm gonna have a sip of tea here. It's important to stress the macro level of causation. Things like patriarchy, things like the concept of health and how we got to decide what health is, because these kinds of biases are ingrained in society and we often don't consider how prevalent they are or that they even exist. So I'll just take a look at some of the severity and health risks when it comes to eating disorders. Eating disorders have the second highest mortality rate of any psychiatric disorder. Only opioid addiction is higher. And eating disorders have a high incidence of suicide and health complications. All eating disorders, I repeat, all eating disorders can cause death and lead to suicide and health complications. And with that, I want to highlight point 3 here, that doctors may not identify malnutrition from an eating disorder in patients with bigger bodies because weight loss may not be seen as unhealthy, even though, you know, they may be losing way too much weight at one time or just doing it in a way that, again, is involving restriction and all of those kinds of things. It takes bigger bodied patients 9 months longer than smaller bodied patients to seek treatment. And people who have bigger bodies are victims of weight stigma in the medical community and society, which has negative physical and mental health consequences. Suiton's research shows that body shaming and sizeism shortens life expectancy regardless of body size. So when we feel ashamed of our bodies, when people are commenting on our bodies, we actually may not live as long. Weight stigma is often internalized with guilt and shame, and is linked to increased physical and mental health difficulties and a poorer quality of life. Again, that all is because of Sutton's research there. So knowing how serious eating disorders are, what are some reasons that eating disorders are maintained? Well, an eating disorder or disordered eating serves a lot of functions. So it can be incredibly difficult to stop engaging in them. Here are some reasons why. I'll just highlight a couple. Preservation of family and relationships. Eating disorders can divert attention away from problems in a family or a relationship. They can be a safeguard against failure. If you're unable to pursue goals because of your ED, then it's hard to fail at any other goals. Self-concept. They can provide a sense of pride and accomplishment from meeting eating disorder related goals. And you may not be getting this kind of sense of accomplishment from anywhere else. And as well, that idea of like punishment or self-harm, that idea of like, I don't deserve a healthful body. But again, it's at this point where I kind of take a little bit of exception for when it comes to the binge eating population. This article was written by Dolhanty in 1998, and that was long before binge eating disorder was even a diagnosis. People knew it existed, but they threw it into that like offset category, that other specified feeding and eating disorders, where just kind of things go when they know they exist, but aren't quite sure what it's all about. Again, binge eating disorder wasn't considered as serious. And that had a lot to do with societal attitudes towards folks with bigger bodies. Research has existed for over 60 years that says dieting doesn't work. People just don't want to believe it. And that includes a lot of doctors. So this is a prime example of how binge eating disorder, the most prevalent eating disorder in North America, is sidelined in the eating disorder community. And its othered status from the past affects current attitudes in research literature, the medical community, and again, you know, life in general. Looking at the maintenance factors above, folks who are, folks who binge eat are probably not being social reinforced for like for example, the second point there aren't probably a lot of people who engage in binge eating who are being socially enforced for the behavior. They are probably not being praised for staying large, unlike someone who restricts, who may be getting praised for staying small. Binge eating behaviors don't seem to safeguard against failure, which is also up there. In fact, many of the folks who engage in binging behaviors are being told through societal messages that, hey, these behaviors actually make you a failure. Research shows that binge eating behaviors are more about losing control and impulsivity. So maintaining control, again, that's another maintenance factor that probably doesn't apply to that community. maintenance factors that may be more prevalent for those considering surgery or bariatric surgery are self-soothing, preservation of relationships, avoidance of sexuality, memories and feelings, self-concept, and self-harm. Oop. Nope. There we go. Okay. Now, I find this very interesting. So the prevalence of eating disorders, we know that close to 1 million people in Canada meet the diagnostic criteria for an eating disorder. So I would probably say, 7 million people in Canada meet the criteria for disordered eating. But if we look at some of that, in the general population, 0.3 to 1.5% would qualify for a diagnosis of anorexia nervosa. However, in the pre-surgery bariatric population, that number goes up to 2%. If we're talking about bulimia nervosa, the general population is 1 to 1.5. In the bariatric population, pre-surgery, it's 2 to 49%. For binge eating disorder, 2 to 5. For the bariatric population, 20 to 49%. For night eating syndrome, 1.5 to 5, and in bariatric, 7.8%. In fact, all eating disorders have a much higher or have a higher rate in the bariatric population, all eating disorders, but we especially see binge eating disorder. And because binge eating disorder is so prevalent in the bariatric population, I want to look at some challenges that the binge eating disorder population faces that kind of co-occur with that, and therefore have higher rates in the binge eating population, or sorry, in the bariatric population. So if you have a BED diagnosis, it's associated with higher levels of psychiatric symptoms like major depressive disorder, other mood and anxiety disorders, substance use challenges, personality disorders, I hate that term, and even ADHD. And again, that transfers over to the bariatric population, that they're also struggling with a range of mental health challenges. People with BED are more likely to report impairment in interpersonal relationships and at work due to distress about eating and weight. They are also more likely to report challenges with self-esteem and their sexual life than weight match controls. And this is a great time to point out that social determinants of health that help create these co-occurring challenges, like access to healthcare, racism, weight stigma, food security, trauma, environment, and stress, that depending on your viewpoint can contribute to these other co-occurring challenges, or they can just full out be the cause for these co-occurring challenges. And a large component of all of these co-occurring challenges has to do with the ability to process emotions. Okay, so let's take a minute here. Yay, quiz time. There are 9 things here that could be the sign of an eating disorder, or they could be the sign that you have just had bariatric surgery. So I just want people to take a minute and just to yourself kind of go through the list and think, okay, bariatric surgery or eating disorder. Do 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 do. That was the Jeopardy end there for those who for those who wanted to know. Well, I'll give you the answer here. All of these are both. You may have just had bariatric surgery if you're restricting your food intake, or you may have an eating disorder. You may have just had bariatric surgery if you've limited food portions, or you may have an eating disorder. And that, of course, goes for everything on the list. Obviously, bariatric clients are instructed and taught to change their eating behaviors after surgery. Limit your meal size, chew food extensively, follow strict schedules, weigh and measure your food, avoid foods. And in the general population, these exact behaviors are what a doctor would use to diagnose an eating disorder behavior. So the answer, in bariatric surgery, these behaviors help heal new stomachs and fight vitamin deficiencies. However, these behaviors can lead to very concerning behaviors and even create eating disorders in individuals who have had an eating disorder previously, or are adapting their eating disorder for this new post-bariatric surgery world, or create new eating disorders. So some things to consider here for all of us, and especially those who are working with individuals in bigger bodies and those who are considering bariatric surgery. It's important that we reflect on our biases, beliefs, and assumptions. Am I treating someone differently because of their weight or size? Do I ascribe fault to a person for their weight or health status? Do I moralize food choices as good or bad, and voice this? First, well, we don't want you moralizing your food choices anyways. And I'm not in this, I'm not saying like somebody being like, oh, you're eating such and such, that's bad. But those more insidious conversations that can happen, like, oh, well, for the next 3 days, I'm eating kale and cayenne and, mushing it into lemon juice because I want to refresh and rejuvenate. And, these kinds of things that are questionable, but somehow sound healthful or like it's appropriate. It's not. And do I consider the social determinants of health in regards to weight? And again, social determinants are things like poverty, disability, food insecurity, Aboriginal status. And research has shown that social determinants have a more significant impact on weight than diet or exercise. It's important that we're aware of the language we're using when we're talking about ourselves and others. Even compliments can reinforce unattainable standards of beauty and diet mentality. We don't want to make assumptions about a person's health, their symptoms or life experiences based on their body. Just a reminder, any size body and any person can be experiencing an eating disorder symptom and any eating disorder symptoms. And we really want to empathize that being in a bigger body can come with a lot of challenges, most having nothing to do with food or exercise, and that food is an important coping mechanism to a lot of people. And just I'll reinforce that for those who do work with the bariatric population or for people in bigger bodies, that we need to provide holistic, individualized care that acknowledges and addresses social determinants of health. We need to build rapport with clients, and that requires communication, a positive attitude, and time. So, eating disorders, pre and post surgery. I know this is like a lot of words on this slide, but I promise we can get through it. So, eating disorders are considered psychological problems and can be fueled by guilt, shame, and low self-esteem, and they can be prevalent among patients with bigger bodies. In this research, Hillstrom and Avila sampled nearly 300 bigger-bodied individuals that qualified for bariatric surgery. 66% had a lifetime history of an eating disorder. 48% met the diagnostic criteria for binge eating disorder at the time of their preoperative evaluation for the bariatric surgery. And of that 48%, 28.8 developed bulimia nervosa post-surgery. Now, I will say that that sample that Hillstrom and Avila had, it wasn't generalizable to the whole population. It wasn't enough people across different cultures and things like that. But I think it's important to take note that that's a lot of different eating disorders that came up, existed, were born out of bariatric surgery. Really something to pay attention to. The literature suggests that the emergence of eating pathology after bariatric surgery is likely underreported and misidentified in clinical settings. So questioning if a client is losing weight because of new eating patterns that have been suggested post-surgery, or if they have taken those behaviors to an extreme and developed an eating disorder, is important, although very rare. But we have seen that some doctors are paying attention, and one of the ways is by the creation of that new proposed diagnosis, post-surgical eating avoidance disorder. But I want to highlight that pre-surgery eating disorders do not disappear because of surgery. They don't. And that's because, like in that iceberg slide, we learn eating disorders are not just about food. They're about a lot of other things. And so even though for individuals who have had surgery, it may feel at first like, hey, some of that stuff I was really challenged with, that binge eating disorder before I had surgery, you know, it feels like it's gone away. It's been a year. You know, eventually those kinds of things, if we don't deal with the core issues, they come back. They come back and they present themselves in new ways. I'll talk about that a little more later on. In some patients, vomiting due to plugging may evolve over time into vomiting. Sorry, just let me move this, make sure I got all the things. Yeah. In some patients, vomiting due to plugging may evolve over time into vomiting as a means of weight control and/or develop into bulimia or anorexia nervosa. So for those who don't know what plugging is, post-surgery, the stomach is a lot smaller, and the shape of of where your food goes in changes. And if food isn't chewed properly, or depending on the type of food, it literally can get plugged up. And at the beginning of bariatric surgery, the bariatric surgery journey, doctors will often say, because it's very uncomfortable, it's very, very uncomfortable, it's painful, that it's okay to make yourself ill to kind of get that food out. And a lot of folks go, hey, oh, wait, so there's a way that I can eat without actually getting all of those calories that are going to, you know, affect how my body looks. So yeah, that's what plugging is, and it does become a type of eating disorder after, or can be a plugging. It's called plugging purging disorder. The next point here. 25% of post-bariatric clients report subjective binge eating, but only 3.4% met full criteria for BED post-surgery. I talked a little bit about that. And in 2014, 8% of patients admitted to the Johns Hopkins Eating Disorder Program had a history of bariatric surgery. That breaks my heart. And I think what's really an important takeaway from that point is that, again, people are not being supported when they need to really take a look at their eating disorder behaviors pre-surgery, and that there may not be support for them with their bariatric clinics post-surgery. So some of the eating disorder symptoms that happen, or that can happen, after bariatric surgery: excessive restriction. There can be some unrealistic expectations about weight loss. And so when folks feel like they haven't lost enough, or that they're gaining food back, or they're gaining weight back, they again can go into excessive restriction. There can be a preoccupation with food and food avoidance, and just simply not following post-op recommendations. That might include not eating as much carbs as you should, or things along those lines. We can also see binge eating after bariatric surgery. And that's that subjective binge eating I talked about, or kind of a constant grazing that feels like there's a loss of control. We talked about vomiting or plugging, and how it's common early post-surgery to alleviate discomfort, but it can turn into a way to prevent weight gain. And then we talk about body image distress. I don't think this point is given enough attention pre-surgery. I mean, yes, there's fear of weight gain, but there's a huge fear that people's pouch or stomach will stretch, a huge fear or dislike about their body because of loose skin. I think I talk a little bit more about that, but I'll repeat myself if I have to. 95% of individuals have loose skin after surgery, and it can be really upsetting for folks. And other ED symptoms that can happen after bariatric surgery: excessive exercise, depression, and anxiety. Whew, I know I talk a lot very quickly in this, so thanks everyone for staying with me. I'll just take a sip of tea here. And to address those kind of symptoms that I was just talking about, we need to look at root causes and support individuals in developing alternative coping strategies, things that go beyond diet and exercise and deal with the internal emotional landscape of folks. And sadly, there aren't a lot of resources to be able to do that at the bariatric clinics here in Canada, or really anywhere when it comes to bariatric clinics, because it's kind of a numbers game. Anyways, post-surgery health risks that are related to ED. So post-surgical eating avoidance disorder, again, that's that definition that we talked about. Plugging purging disorder. I want to mention addictions. This is a very serious health risk that's related to eating disorders. I'm bringing some up that are, again, at that intersection of eating disorders and bariatric surgery. There are other risks that should be considered before one engages in bariatric surgery. I'm just discussing the ones that are related to eating disorders. So I'm bringing up here, let's look at addictions, where folks who are unable to use food to regulate emotions in the same way, and they may turn to substances or behaviors to regulate emotions. So that can be things like drugs, alcohol, gambling, or they may engage in addictions because of new stressors that have become after the surgery, things like relationship changes, which may lead to addictive behaviors. This is actually one of the biggest or the most frightening aspects of surgery. 20% of people who have had a gastric bypass surgery develop an alcohol use disorder. That is more than 3 times the rate of the general population and a real cause for concern. And those who have Roux-en-Y bariatric surgery, which is considered the gold standard in Canada, it's a great surgery if you're having bariatric surgery. It's the most common, but those who have it are 3 times more likely than those in the general population to die of drug or alcohol related causes. And that isn't because of psychological reasons or any of that kind of stuff. That actually comes down to physiological changes in the body. So that research just came out last year. That's frightening. That's scary to know. As well, there are a lot of body image issues. This is where I was talking about things like loose skin. Bariatric surgery is covered by OHIP, but surgery to remove loose skin is not and is very expensive. Loose skin is often not part of the body that folks imagine that they'll have after surgery. And so, yeah, it can be a real bummer to have to come to terms with this new body when you thought you would have a something much more aesthetically pleasing, whatever that means, but that to you the thought was that it would be more aesthetically pleasing for you. So it can be really difficult. And then we see down here, emotional eating, subjective binge eating, and loss of control eating, and they correlate. So folks who engage in these behaviors often correlate with people who gain the most weight back after the first year of surgery. So these kinds of disordered eating behaviors, again, we really need to support folks, get a handle on them so they can be successful in their goal to have a good surgery. And just to look a little bit more at that, I won't read these points, but they all kind of say the same thing, that the ability to identify, understand, and process one's emotions is crucial for those at the intersection of bariatric surgery and eating disorders, especially to confront emotional eating, binge eating, and loss of control eating, addictions, and mental health challenges. Not only because it will help them feel like their surgery is a success, which technically I don't care about because I'm a social worker and not a medical professional, but because of the things I do care about, which is that it improves, it helps them with their self-worth, mental health, overall quality of life, and whatever goals they themselves have put in place for themselves. So what is Sheena's Place doing about this intersection? Well, Sheena's Place runs a 10-week group that is part support group, part skill building group, but that is not a treatment program. The skills aim to build or support emotion regulation and are adapted from dialectical behavior therapy, cognitive behavior therapy, and acceptance and commitment therapy. And as a group, the topics that the group gets support on are chosen by participants. They choose 9 topics of interest from a list of 15. The topics choose what skills are learned. This group is currently for clients who have been accepted into a bariatric program or who have had bariatric surgery. Research shows that the 2-year mark post-surgery seems to be when clients need the most support. But of course, a lot of clinics aren't able to follow clients beyond 1 year. They just don't have those kinds of resources. So Sheena's Place recently ran a pilot of this group. I'd like to share some of the successes and some of the opportunities for growth that came about. The feedback we received is being implemented for our next session, which will be in March, and sign up will happen at that time. And this includes, some of the opportunities for growth included the need for group members to have that support aspect, especially during COVID-19. Folks really wanted to talk about their experiences in a bigger body or a disabled body, as many folks who came had mobility issues. They wanted to talk about being in a female body that others viewed as bigger. And they felt they hadn't had a place to talk about the pros and cons of surgery in a comprehensive kind of way. So we really wanted to honor that space, and looking to do more of that in the future, especially where in a way that it felt that individuals were allowed to change their minds about having surgery, if that's what meeting others who had the surgery, who were further along in their journey, if that really started to resonate with them, that, well, actually, maybe I don't want to go through with the surgery. Having the space to be able to say that was really important, as well as honoring the choices of having surgery. It seemed folks were often told to go home and think about surgery by doctors or clinicians or whoever, but without really having a clear parameter of all of the issues that it would be helpful to think about. So I'll just put this up here. These are all of the topics that individuals could, or the group could decide to choose so that we could talk about them. It was just kind of a majority wins. They did a survey, and those were the skills that were considered to go with them. In week 1, the pilot group's topic was the orange one here, orientation, learning about emotion. And the skill we were to learn about was noticing and identifying emotions. And the plan was to keep that the same for every group that ran. But that was another learning, that this group really needs an opportunity to learn about one another, to build trust with one another, and discuss the reasons and frustrations that brought them to the group, whether they were on the list for surgery or had surgery. It was a niche population. They wanted to talk about that, and they wanted to make sure that others in the group were at that place too in some way. So for the future, skill learning will not be a priority for week 1. That's something we learned. And in fact, learning a new skill each week, which was the original plan, just doesn't feel conducive to the needs of the group. some of the skills some of these skills you can tell are complex, like the model of emotions, which is from DBT, which we use in feeling big emotions. It's just too big of a skill to try and jam into one session. And and it just felt like people were kind of having to walk away, not really learning the skill, and therefore being able to apply it to the emotion regulation things that they needed to apply it to. So yeah, having big skills split over 2 weeks is I think something we'll do going forward. And finally, we realized that remote learning is key. There was interest in the group from almost every bariatric clinic in Ontario. So mailing out a workbook of some sort, since we ran into challenges having clients download notes, would be helpful just for accessibility purposes, because there were a lot of notes in this. And the successes of the group, we identified a service gap in the current eating disorder and bariatric landscape. Once again, by the way, my notes have cut off. So other successes were that the group really came together well, and it really felt like a place where folks just didn't have the opportunity to share some of the things that they were sharing in this group. As well, I think perhaps the most important one is that this very niche group of eating disorders and bariatric surgery, there really aren't a lot of services, really, for this group. So to be able to have a free group where they could work on the aspects they wanted to work on was really, really important. Another reason why donating to Sheena's place is such an important thing for us to do. And these are just some of the modalities, the evidence-based practice of like why we chose CBT, DBT, etc. This was the research and the evidence of how it improved emotion regulation. I'll just go through that quick. Yeah, and just to read this out, Hillstrom and Avila state that until bariatric clients learn healthful coping mechanisms and effective emotion regulation, they will still rely on food to cope. And that's the truth, right? And that's why I'm so passionate about having this group. Here are some great resources for those who are looking for eating disorder treatment and support. The online support is helpful, of course, for accessibility and for those with body image concerns. But I will say that most treatment programs don't have any kind of consistent binge eating disorder program, or are aware of the intersection of eating disorders and bariatric surgery. And that's even in hospitals. So here are some great virtual supports, like I said. NEDIC at the bottom there has a great, NEDIC, the National Eating Disorder Information Center, has a great database of professionals who work with people who need eating disorder treatment. And I will say, in terms of psychologists and psychotherapists, I have a list here of those who deal with bariatrics, are aware of bariatrics. Most of them are doctors, and therefore are quite expensive. And I will just say that I'm unaware of the level of awareness that some of these folks actually have with eating disorders. You know, it's easy to get one, but it's hard to get like eating disorders and bariatrics, or bariatrics and eating disorders. And mindful eating resources are listed at the top, but it should only be considered under the guise of a professional. It is not appropriate for all eating disorders or all stages of bariatric surgery. There are some great articles I list here about bigger bodies. And with that, I guess we will close this up and come to questions. There are a ton of references here. If you want them, you can contact me and I'm happy to pass those on. Whew! Geez Louise, that's a lot of talking.
So Sam, we have a couple questions in the chat. So I just want to make sure we get to those before we open it up to more. So the first one is, oh, let me find it okay. So the first one is about a care team. So my understanding is that if you go into a bariatric program, you receive a care team, which includes a psychologist to help with eating disorder. Is that true?
Yes and no. So I can, let me brief you on the process of what it's like. So you go in, you have an orientation, you're given a nurse, a social worker, a dietitian, but you don't work with those folks on an ongoing basis. What happens is you go to the first one, which for me was the social worker. You go to the social worker, she like, tell me about this, tell me about that, what is this, what is that? And then she checks you off of like whether it's like, okay, it's appropriate for you to continue down this path of bariatric surgery, or I'm gonna flag you, maybe for example, maybe you had a parent die 3 months ago, and they want to make sure that this is a choice that you are fully thinking about, that it's not like a moment of grief that has kind of led this. So then they'll say, well, let me give you some extra time, come back and see me in 3 months. And then when everything goes well with the social worker, you get a check, and then they send you on to the next person in the list. I will say, if the social worker finds something that's maybe not grief, but something like perhaps an eating disorder, they will send you to the psychologist, but the psychologist is not a guarantee. They are there for folks who have mental health challenges and things like that. And they're really there to be like, can you do this? Is it a good idea that we set you up for this? I mean, I don't want to speak ill of any of bariatric clinic. I think they do a really, really good job, but self-advocacy is really, really important. If you need to identify if you need resources. If you say, hey, I'm having challenges with binge eating, I need resources, they'll provide you those resources, but it's not like they're running groups or not often for like mindful eating or things like that. And if they are, that could be a waiting list until after you're done your surgery. So I hope that answers the question. So it's not so much a care team as different people that you need to advocate to. And sometimes that can be hard because you don't know sometimes a person doesn't know what they need to advocate for. And that's the trick.
Thanks, Sam. We have another one here about the pilot group. So this person asks, did you have an opportunity to share the feedback from the pilot with the Humber Bariatric Program or other hospital programs? Understanding this feedback might help them better support post-weight loss surgery, especially after the first 2 years.
I would love to provide that feedback to all of the clinics in Ontario. I've been lucky that they've been very supportive. Um, However, we've only run one group for 10 weeks. I need more information to really feel like I was giving, or that, not even that I'm giving, that the participants were giving information, that I had enough of that client participant information to provide, a good basis, a good foundation. But that's definitely something that needs to be